That was really excellent. So we'll go straight on to the next.
Yeah, so I'd like to introduce Dr. Andrea Filippi from Istituto Nazionale Tumori from Milan, Italy. He'll be presenting on chemoradiation is the preferred option regardless of operability. Thank you very much.
Thanks to you. Good afternoon. And thanks also to my colleague for his presentation. So, very nice topic. One of the, I think the point that we need to think about what we consider oncogene-addicted early stage non-small cell lung cancer is that it's a bit different from all other diseases, and especially EGFR mutated, but we could say the same for ALK translocation or for other driver mutations. And in this kind of tumors, as also Dr. Wakely said this morning, survival is really dependent on what are you giving as systemic therapy, the duration of systemic therapy, the level of resistance. So the main driver for survival is systemic therapy. And you can see it very well if you look at how many patients are cured by surgery and placebo, by surgery alone in the ADAURA. And if you, here there are also stage 2 patients. If you look at the curve for stage 3A, it's even lower. It's like the LAURA curve. So one can discuss what is the role of local therapy. That's what we are discussing now. And for sure, the role of surgery is completely different from non-oncogene-addicted tumors. And the same is for chemoradiation. The control arm, look at the control arm of the two trials. They are very bad. And we are seeing survival rate that we are not used to see, neither with Pacific regimen or with neoadjuvant or adjuvant regimens after surgery in non-oncogene-addicted populations. So it's a completely different landscape. Provocatively, I think that we are curing more patients with limited stage small cell lung cancer with chemoradiation, stage 3, even without immunotherapy. Just look at the control arm. We are curing more patients with small cell lung cancer than patients with EGFR mutated lung cancer with either surgery or radiation. And this means something. But why? Because obviously, these patients have such a high propensity to metastatic progression, especially in the brain. The reasons for the clear and so incredible benefit of using osimertinib after surgery or after radiation depends on the capability of the drug to decrease substantially the number of new lesions in different organs, and especially in the brain. Then we have the problem of how many years until progression, etc., resistance, second-line therapy, and it's not my topic, but obviously this is evident. And overall survival of the LAURA trial is also very nice to see that on the opposite, we have unprecedented overall survival. Because it's like osimertinib is so able to control systemic disease that if you use a local therapy like chemoradiation in more advanced stage, because you cannot compare LAURA and ADAURA regarding to stage, because in ADAURA, much more patients with earlier stage were included, stage 2, 3A, while in LAURA there were stage 3, B, C, etc. But I mean, 84% of survival at 3 years for a stage 3B, C tumor with chemoradiation has unprecedented results. So the control arm received 81% of crossover. We know it very well. We don't know what's going to happen in the next year to this curve. I mean, in this trial, as you know, osimertinib is given indefinitely until progression or until toxicity. So we will see. But when I see this curve, I'm very impressed. So in a way, we are trying to cure a lot of patients for sure. We are curing a higher percentage of patients. So at the end, given the high likelihood of metastatic disease in stage 3, what would you prefer? as a local therapy, what is your primary choice? Like, it's like small cell lung cancer. I mean, it's like, what is your primary choice? So one could be no local therapy at all because it's just the same. It's an illusion, stage 3, oncogene addicted, and an illusion of surgeon, an illusion of radiation oncologist. And basically, these patients need to be treated with a systemic therapy alone. I'm not convinced about that. Unfortunately, also many other colleagues are not. Or you can use TKI, with or without chemo, we will see in the near future. You can use it before or after local therapy, while I think consider local therapy essential for a potential cure. And this is the main point of my talk, because if you say yes, local therapy is important. Now, what is the best local therapy for a disease that has such a high propensity of metastatic dissemination? Is surgery where you need to dissect, and sometimes you need to dissect stage 3, so it's quite difficult in point of technical, morbidity, costs. So why using a less toxic, we'll see, less toxic, it depends obviously on the volumes, on the technique that you use, but could say that probably could be less toxic. The one after the long-term curative of life, we don't know, but I am in favor of, in this debate particularly, even if I have many doubts, obviously, the one that is more easy to combine with systemic therapy and the one that can be adapted to response, because when we will have the neoadjuvant results, and for example, your tumor, your stage 3B tumor shrinks and the lymph nodes, the primary tumor and the lymph nodes, you can very easily treat them with radiation. So that's why I have a candidate for what is the best therapy in a disease like this. Because it's much more easy, much well tolerated, very, very easy to be done, and it's able to control very well what patients, exactly resectable patients for sure, unresectable, not so much, but in combination with neoadjuvant therapy, I think yes. So the toxicity profile is completely superimposable, and it depends on the toxicity profile of osimertinib alone. We would need to go more deeply into the radiotherapy-related complications and surgical-related complications. It's not easy to do it. We don't have so many granular data regarding this, and we don't have quality of life data. But probably in terms of tolerability of OSI as consolidation, the toxicity profile is the same. So I have more questions than answers, as always in oncology. I'm sure that TKI are highly effective when used after surgery or after radiation, and we need to know if they will be useful also before. Can local therapy be seen as a debulking consolidation? I think yes, because at the end, it is probably a micrometastatic disease, but local therapy uses consolidation or debulking as a role, and we can probably predict who's going to respond at different time points through molecular response and ctDNA, and this will be very useful for us to modulate the local therapy, and probably we can also think about eliminating the association of chemoradiation that we use in oncogene-addicted tumors if you use chemoradiation before. So for example, chemo-OSI, chemo-TKI, and then radiotherapy, and then maintenance osimertinib, for example. That would mean lower toxicity and very easy access to the cure. So at the end, I think we should rethink the role of local therapy, and for patients with low tumor burden who are resectable, probably in this case of oncogene addition, given the results of surgery and of radiation therapy alone that are really superimposable, probably it's better to both have a very good chance to be successful because the main driver is TKI. Do consider to use radiation when you have the possibility to do that because it's really easy to perform and has a high chance of control the disease. For patients with high tumor burden, so the Laura patients, for example, probably in the future we will have neoadjuvant chemo-TKI, and then you can use CRT followed by TKI. It is the preferred choice to me because you can avoid unnecessary surgery in very complicated cases, and you can improve the chance of local control and survival with a very good quality of life. And then, obviously, we will have the possibility in the future to use molecular residual disease. So I don't know if I convince you. I'm not fully convinced of myself because I have many doubts regarding this topic. But what I really think is important, if you look at the control arms of the trials, is it's really, in this case, the impression is really that surgery and radiation are doing the same because the disease is really disseminated from the very beginning. And as we do in small cell lung cancer, probably applying aggressive surgery in these patients, in my opinion, is not the right way to cure them, because they're probably being cured very well also with a limited field. Let's say, using the best technology, obviously using and having radiation oncology experience in treating lung cancer. Thanks so much.